Hi, everyone. Nice to see you all, and it looks like we have a great turnout for today's session. Dr. Chris Waite and I will be your moderators throughout the session, and we're going to say the eye of the storm, talking about our pediatric research. I would ask that anyone that has any questions, please direct the questions to the Q&A box. And what we will do is we will have after each set of 3 research presentations, we will take a 5-minute Q&A session. Without further ado, we will start with I will let Chris introduce our first speaker.
Hello, everyone, and thank you very much, Stephanie. Our first speaker will be Dr. Paul Huang with the topic of comparison of GROP versus WinROP algorithm in predicting sight-threatening ROP.
Thank you. Can you hear me okay? I'll presume that's a yes. My name is Dr. Huang. As you see, I'm PGY 5.994, about 3 days from finishing residency. Thanks to the team, Dr. Hill, Dr. Dodge, for their help in this. We have no financial disclosures. Infants at increased risk of developing ROP require screening eye examinations. However, ROP ocular examinations cause pain. Increase in adverse physiologic events such as cessation of breathing, oxygen desaturations, and bradycardias. Our ROP screening guidelines are based on the criteria of low birth weight and gestational age, with roughly a 99.6% sensitivity. These criteria, however, have low specificity for type 1 ROP, that is ROP that requires treatment, as only half of examined infants develop ROP, and only 7% of examined infants receive treatment. In our center, that number is as low as 1%. Infants requiring examinations receive roughly 10 exams on average, so this is a lot of exams that the infants get. WinROP is an algorithm that identifies infants at risk for developing ROP requiring treatment. An alarm is triggered if there's a disparity in predicted weekly weight gain and actual weekly weight gain. And if that happens, these infants go on to get screened for ROP. It's an online tool with high sensitivity, roughly 98.6%, but possible low specificity in some studies in extremely preterm babies. The GROP algorithm utilizes 6 specific criteria, and initial validation studies have been promising. However, GROP has not been validated in a Canadian population. GROP in the original studies predicted all cases of type 1 ROP requiring treatment with 100% sensitivity, and reduce the number of infants receiving examinations by 1/3. Maintaining a test sensitivity of approximately 100%, as with our current screening guidelines, is critical because of ROP's high morbidity and what we would lose if we missed these babies. However, in our center, less than 1% of all screening results in treatment for our infants. We are in immediate need for reliable methods to reduce the number of eye exams required to identify infants needing treatment. The purpose of our study was to validate the GROP algorithm and compare its sensitivity and specificity to the WinROP algorithm in detecting infants with ROP requiring treatment to attempt to reduce the number of infants screened. This was a retrospective chart review conducted for all infants admitted to Calgary NICUs from 2013 to 2017, and they were screened for ROP according to our Canadian guidelines. These guidelines were used as a gold standard to determine which babies were screened and treated, and the data was then input into the WinROP and GROP algorithms. The highest stage and lowest zone of ROP in the worst eye before 54 weeks post-menstrual age was recorded, as well as the development of type 1 ROP and need for any treatment. 1,000 infants were included, mean gestational age roughly 28 weeks, mean birth weight roughly 1,100 grams. WinROP had a sensitivity of 95.7% and a specificity of 46% in predicting infants who required treatment for ROP. 44 of the 46 treated infants had a WinROP alarm trigger, however, 2 did not, and those 2 not detected were both large for gestational age, and 1 had Turner syndrome. GROP, however, had a 100% sensitivity in detecting all infants who required treatment, and it had 50% specificity, so higher than WinROP as well. There are approximately 3,300 very preterm infants admitted to Calgary NICUs annually, with about 30% requiring screening visits and almost 1% requiring treatment. WinROP did not detect 2 infants with type 1 ROP requiring treatment. As I mentioned, these were both large for gestational age and one had Turner syndrome. WinROP may be effective in detecting ROP requiring treatment in our Canadian population, but should be used cautiously, especially in infants with a high birth weight and genetic abnormalities until other predictive factors are known. GROP, however, was able to detect all infants requiring treatment for ROP in our large Canadian cohort. Utilizing GROP instead of the current Canadian screening guidelines would result in 600 less babies requiring examinations annually. And if these screened babies received roughly 10 exams on average, this would equate to roughly 6,000 exams that we would not have to do every year. So while further validation studies are needed, GROP is a promising screening tool for ROP and something to consider to be used in conjunction with our guidelines until it is further validated. These are my references, and it looks like we're just under the 5-minute mark. Thank you very much.
Thank you very much, Dr. Wong. I'd like to introduce Dr. Nazrin Tarani, who's speaking next. Her topic is the 6-year outcomes for bevacizumab treatment for type 1 ROP.
Thank you very much for giving me the opportunity to present. And I'd like to thank my collaborators who have worked on this project with me. We have no financial disclosures, and I will be talking about the off-label use of bevacizumab for treatment of ROP. Intravitreal bevacizumab has now been accepted as treatment, particularly for disease in zone 1 after the publications of Beat ROP and other case series. Our own experience at 1 year has already been published in JPOS. The reason for use of this medication, particularly for zone 1, can be illustrated by the pictures that you can see here, with the top 2 photographs taken about a week before treatment and the bottom 2 taken at about 10 months after treatment. And as you can see, that shows the extent of vascularization that can be completed between the same eye over a period of 10 months. Our purpose is to report larger term outcomes following treatment with bevacizumab in terms of structure, visual acuity, and refractive error. This is a study taken over a 5-year period for infants treated between 2010 to 2014, and it's retrospective. We included all consecutive patients who had type 1 ROP and received a single injection, and they had a minimum follow-up of 5 years. We excluded all infants on whom we did not have data at 5 years, and these were infants who were either transferred out of the province or our immediate area. 1 infant died at 5 months of age. The primary outcome is the structural outcome as defined by ETROP, and the secondary outcomes are monocular visual acuity reported in logMAR and refractive error reported in spherical equivalent. Here's our results, and you can see the number of infants were 26 with 45, so 7 infants were treated unilaterally. The mean gestational age is shown, and the birth weight and the mean post-menstrual age at treatment was approximately 38 weeks. The ratio of male to females was almost 2 to 1. 73% had treatment, bilateral treatment, and in terms of eyes, 5 eyes had zone 1 disease and 40 zone 2. Looking at the structural outcome, we're happy to report that all eyes had favorable structural outcome in our cohort. In fact, no eyes, although some developed disease recurrence, didn't require any treatment for that recurrence, and that's important in the terminology. We did have 1 eye that showed a failure of regression after treatment, and you can see that illustrated in this image here. This was a very ill child who had multiple resuscitations, and this child developed a persistent vascular band that can be seen lighting up in the fluorescein angiogram here, and this area caused vitreous hemorrhage. This infant needed laser at 58 weeks postmenstrual age. In terms of visual acuity, You can see the vision in terms of logMAR and the time on follow-up. So in fact, 91% had favorable outcome. We only managed to get visual acuity in 35 out of the 45 eyes. The spherical equivalent was myopic, and in our current study compared with beta-ROP, you can see that we had higher myopia, and this may be because we had a longer follow-up compared with beta-ROP. Most of the infants were emmetropic, but we had a larger number who had very high myopia. So at 6 years, all eyes had favorable structural outcome and 91% favorable visual outcome. Only one child failed to regress, and the rest that did develop any recurrence did not need treatment. There was higher degrees of myopia in comparison to beta-ROP, and emmetropia occurred in 50% of eyes. So this study provides more information on the long-term outcomes of ROP in eyes treated with bevacizumab. The fact that there was lack of retinal detachment and other late ocular complications in the present study is encouraging. And this data provides useful additional information that can be provided to parents during the consenting process. We are planning further studies to evaluate visual function, including visual field testing. Thank you.
Thank you very much, Dr. Trani, for that great talk. We're going to pass the speaker back once again to Dr. Paul Huang, who will be speaking this time on reducing neonatal pain scores during ROP screening.
Thank you, Dr. Wade. So same team again. Thank you again, Dr. Dotch and Dr. Hill and the rest of our group. This is entitled Pain Scores for ROP using Lid Speculum versus Finger Technique. If you're just tuning in, I'm Paul Huang, PGY 5. We have no financial interests. So ROP exams are associated with apneas, bradycardias, and feeding intolerances up to 48 hours after examination, often necessitating additional care and monitoring by NICU staff. Adverse events relating to screening have been partially attributed to the adrenergic effects of mydriatic drop administration prior to the examination. But the most painful part of the exam has been correlated with insertion of the lid speculum and scleral depression. This results in an acute pain response when measured on neonatal pain scores and causes destabilization in physiologic indices, including increased heart rate, increased blood pressure, and decreased oxygen desaturation. An alternative is to perform the exam without the use of lid speculum and scleral indentation, but rather with the use of fingers in appropriate positioning of the patient. As can be seen in this image here, the examiner opens the infant's eyelids by applying gentle pressure to the tarsal edge of the lid margins with the thumb and index fingers, and the baby is rotated appropriately. The purpose of this study was to compare pain scores of infants screened with lid speculum and scleral depression versus infants screened with the finger technique. This is an example of the finger technique. We see a version of both the upper and lower eyelids, as well as depression at the tarsal edge using the fingers while rotating the baby appropriately. "88 infant exams were undertaken and randomly assigned to either exam with lid speculum or exam with finger technique. This was performed by 2 experienced ROP screeners. All infants had the same neonatal comfort measures, including swaddling, sucrose, and dim lighting. The duration of exam, the exam view, and ease of performing the exam was documented. In the lid speculum group, topical tetracaine 0.5% was instilled 1 drop in each eye before the pediatric lid speculum was inserted following examination. Tetracaine was not used in the finger exam group. Pain scores were assessed using the premature infant pain profile. We used both the older PIPP and the newer PIPP-R pain scores. We used a repeated measures design in which infants contributed scores to both groups. 45 infants were screened using the finger technique and 37 using the lid speculum. 5 of those examined with the finger technique were converted to lid speculum, and we'll talk about that later on. These are the demographics of our infants screened. They were essentially the same between the 2 groups, including gestational age, birth weight, and postmenstrual age at the time of exam, and none of the differences were statistically significant. The mean length of examination with lid speculum was 2 minutes and 1.8 minutes for examination with the finger technique. However, this was non-significantly different. The exam view and ease of exam view were graded subjectively by the examining ophthalmologist and are presented in this table. Half of both the lid speculum exam and finger technique exams were graded as easy. 3/4 of the exams views, both in the lid speculum and finger technique group, were considered easy. 5 infants, as I mentioned before, were converted from the finger technique to speculum for the reasons highlighted here, including poor view, periorbital edema, and poor dilation. This table highlights pain scores before, during, and after examination with lid speculum in blue and the finger technique in orange. Using both the new and old PIP scoring systems, the pain scoring systems, pain before and after were similar, but were higher in the exam in the lid speculum group, regardless of the type of pain score used. This is a distribution plot with the mean PIPP-R scores on the y-axis. There's a large main effective group, which means that there's a significant between group difference in the PIPP-R scores. It is interesting to note that the increased variability in the PIP scores in the finger group. So the finger technique in our study resulted in lower pain scores, similar ease of view and exam view. While it does fall short in certain types of CPAP, significant eyelid swelling, poorly dilated pupils, infants who cannot be positioned, or in anterior zone 2 or 3, the conversion to lid speculum is easy if necessary with the use of topical tetracaine. This technique should be considered in examining these ROP infants, as it can result in reduced pain for these babies. Thank you.
Thank you very much for another wonderful question, or another wonderful talk. I'm going to ask a few questions here now from the audience. First question, I guess, would be to both Dr. Tranny and to Dr. Huang, and it's whether you guys feel as though ROP exams should always be performed wearing scleral gloves.
Well, I'm going to jump in here. Well, at the moment, certainly everybody is wearing gloves, and we are also wearing N95 masks, and so full PPE protection for ROP examinations.
Very good. Another question to you, Dr. Tranny. What did you use to determine retreatment in your study? So
we retreat specifically if there is disease recurrence, which involves development of plus disease or development of new vessels. So the criteria for retreatment is not very clear, unfortunately. There is debate as to what should be retreated. And some people also retreat with supplemental laser at a point where they feel the infant's being discharged from the NICU, and they may have difficulty with follow-up for infants that have been treated with injection. In our center, however, we specifically withhold further treatment unless there is new vessel development or if there is recurrence of plus disease. And then if at months later we find that there's a significant area of avascular retina, then we will retreat. And by that, our criteria has been if we've got more than 6 disc diameters from the temporal edge of avascular retina to the temporal aura, that's when we decide to do laser treatment to any avascular retina.
Very good. Thank you very much. You answered one of our other questions with that as well, so that's great. Question to Dr. Huang. I guess there's a couple here. First one is did you always position the babies on your laps? Often when we're doing ROP exams, they're in various incubator. So did you always transfer them over, especially the little ones, or were you able to do your technique also in the standard incubator technique?
Every attempt was made to provide whatever comfort measure we could. Obviously, there are cases where there are physical and mechanical restrictions where we cannot do that. And in those cases, obviously, we did what we could for the examination.
Okay, very good. And there was another question here in regards to using the speculum and indenture when babies are older. Did you guys do that to confirm when they're in zone 3 then?
Yes. Dr. Dodson is nodding, but she's muted, but yes.
Very good. Okay, thank you for that. So I believe we've answered all those questions, except for the type of speculum that you were using in your institution. Was that an open loop type speculum or a closed loop speculum you were comparing it to?
It was a closed speculum.
A closed loop speculum, okay. And were your babies able to have sucrose on with the examination, or was it withheld? Okay.
Yes.
Very good.
Both groups.
Could I make a quick comment there? I think it's a wonderful idea, and I always teach that you always try and do without a speculum. And then if you cannot see adequately, you go to using a speculum. It's actually quite good if you're very flexible and you can actually get your head and neck to bend and you use your spine, you can actually get very peripheral to even zone 3 without a speculum. But that takes a little bit of skill and perhaps doing a little bit of yoga for the person who's doing the screen.
Thank you very much for those comments, and I'll just second that I do the exact same thing as you do now, and I found it's been very successful with the need to use a speculum quite seldom at this point in time. So I think that'll be the end for our question and answer for the first group. So I'll pass it back over to Dr. Dodson to begin the second group.
Excellent, thank you, Chris. So I would like to introduce our first speaker, and that is Dr. Anaz Makar, and she will be talking about photo screening for amblyogenic refractive errors in children, a result from the IC study in Southwestern Ontario.
Hello, everybody. Thanks for the invitation to speak. So I have no financial disclosures. Obviously, the rationale for photo screening is really to reduce amblyogenic risk factors and therefore amblyopia, and to facilitate the work provided by the optometrists for this difficult age group. We chose for our study the hang on for 1 second. Plus Optics S12 C-hand screener, and the camera has 5 built-in default settings, and we chose the ROC 4 curve because we wanted 80% sensitivity and 95% specificity. The camera operators were from the Lions Club and undergraduate students that volunteered to do the screening, and the program ran for 3 years starting July 15. Initially, we screened kids from 18 to 42 months, but then when we got the approval from the school boards, we also screened children in JK and SK. The referral criteria for the criteria we chose is on the screen now, and whenever a child was flagged by the camera, we would send the parents of screened children a report on the screening results. We'd send them educational material regarding vision disorders in children. They were also given a list of contact information for local optometrists and self-addressed and stamped envelopes so that they can return for us the optometrist findings. 2/3 of all the screening happened in daycare centers, so way younger children, and 1/3 occurred in schools after the approval of the school boards. We screened almost 6,000 children, and our failed or referred children rate was 6.8%. 2.9% of all children were not tested. The disappointing part of this program is that we only managed to get feedback from almost 25% of the examined children by optometrists. 27% of the parents opted out of contact completely, and 50% we were not able to get any definite results. So whether the children were never taken to see an optometrist or the parents never communicated with us, that was a big problem. Almost 40% of the screened children were under age 3 years, and they also had the highest untestable rate, but the referral rate was fairly similar among all age groups tested. We looked at the spherical equivalent of all screened eyes, and around 60% were emmetropic, almost 30% were hyperopic, and the rest were myopes. The referral criteria for hyperopia was if they were higher than 2.5 diopters. Obviously, this is non-cycloplegic, so the real hyperopia would be higher than that. And the moderate hyperopes were about 0.7%. The highest thing we picked up is anisometropia. So the 4% of all referred children were anisometropic, 3% were referred because of astigmatism, and 1% was flagged because of hyperopia. That's looking at the patient's occurrence rather than the eye occurrence. When we looked at the severity of amblyogenic risk factors that was identified, 113 children had higher than 3 diopters of astigmatism, and almost 50 children had higher than 2 diopters of anisometropia, whether it was spherical or cylindrical. We specifically looked at the hyperopic children and compared the moderate hyperopes with the mild hyperopes, and the moderate hyperopic children had a much higher percentage of spherical anisometropia and astigmatism, and this has been published in other similar literature. So really, in summary, we screened close to 6,000 children. The program did offer a lot of educational material and created awareness among daycares, parents, or even school. The referral rate was fairly comparable with other studies, 6.8%. We know that Ontario has started a screening program in 2018, or supposed to start through public health. They were going to use 3 modalities: the HOTV visual acuity chart, a random dot preschool stereo test, and an autorefractor. They were going to screen children in SK, and fairly similar, they notify the parents, they send them to an optometrist. The only problem is there is no mandate for parents to take children. So a lot of the literature talks about this, that there is no merit in screening so long as the parents do not follow up on the screening. Thank you.
Excellent. Thank you very much. Next, I'd like to introduce Dr. Yaning Struby, and she will be discussing the right hangback recession with fibrin glue compared to standard fixed suture recession for the treatment of horizontal strabismus.
Hi, thank you, Stephanie, and thank you to COS and COS for the opportunity to present our research. I'd like to acknowledge my co-authors listed here on this slide. So we were interested in how we secure extraocular muscle to sclera and the associated risks. Scleral perforation is a known and potentially serious complication of rectus muscle recession and occurs during the attachment of the muscle to an inadvertent deep needle pass posterior to the rectus insertion. Scleral perforation has been reported to occur in 1% of cases and is one of the most severe complications of strabismus surgery. Hangback recession avoids this complication as the needle passes anterior to the insertion over the pars plana. There is no retina in this area and the sclera is much thicker. Hangback recession also provides better exposure for the scleral pass than the standard fixed suture recession. The problem is that the muscle may not adhere at the desired recession point. And animal and clinical studies recently have shown that the suspended muscle can shift horizontally or vertically, can creep forward when attempting large recessions, and may increase the risk of late posterior slippage and overcorrection. So the question we posed was, how do we make surgery safer and retain accuracy? Many reports are in the literature investigating the use of glue alone for strabismus surgery, and none have been successful due to the lack of adhesion strength of glue alone. Topiwala and Bansal did report successful bonding with cyanoacrylate and fibrin glue, but found fibrin glue more biotolerable. While fibrin glue alone has been shown to not be strong enough as a muscle sealant in animal models of strabismus surgery, it does have the potential of stabilizing the new insertion in hangback rectus muscle recession. A recent experimental study on rabbit eyes by Park and colleagues demonstrated that fibrin glue is effective in stabilizing the new rectus muscle insertion and decreasing the displacement seen in hangback surgery alone. Therefore, with this background in mind, we decided to evaluate the clinical safety and efficacy of a novel hangback recession with fibrin glue for the treatment of horizontal strabismus in humans. This was a retrospective case-controlled clinical study comparing the surgical outcome of the novel right hangback recession with fibrin glue versus standard fixed suture rectus recession in the treatment of horizontal strabismus. The technique for this novel hangback recession with fibrin glue is described in the next few slides. Using limbal incisions for exposure, the muscle is isolated using a grooved hook to protect the sclera from scleral perforation. The muscle is then secured with 3-point fixation over the grooved hook. The hangback modification includes securing the muscle to sclera with a single long scleral pass, 1 millimeter anterior and parallel to the insertion. The long needle pass helps to splay out the muscle and prevent central sag of the muscle that can occur in traditional hangback surgery. The modification ties the knot at the muscle, not at the insertion, to avoid erosion through conjunctiva. Finally, fibrin glue is added between the recessed muscle bed and the sclera, including the hangback sutures as shown, to help prevent movement and displacement of the muscle on hangback and the conjunctiva closed over the glue. We compared retrospectively the medical records of all patients who underwent strabismus surgery by Dr. Wright between 2016 and 18 for horizontal deviations only. 17 patients in each group for either fixed suture or fibrin glue recession were identified and reviewed. The post-op follow-up periods were divided into early, 1 to 7 days post-op, and intermediate, 2 to 8 months post-op. The main outcome measure was surgical outcomes of each group. A good surgical outcome was defined as a post-op deviation less than or equal to 10 prism diopters of deviation with a minimum of 2 months follow-up. Here's a summary slide of our results. 32 eyes of 17 patients underwent each procedure. The patients were similar and non-significantly different between groups in all respects, as you can see, except for the refractive errors between the two groups. The fibrin glue group did consist of more myopic patients. This was expected since the patients in this group were selected for the hangback glue as a safer surgical option due to thinner sclera seen at the time of surgery, which is associated with myopia. Otherwise, all other variables were similar between groups, including mean pre-op angle of strabismus in both ESOs and exos, and the mean post-op deviations and overall success rates between the two groups, with no complications in either group. In conclusion, the right hangback recession with fibrin glue was found to be safe and effective, with postoperative results not significantly different than standard fixed suture recession. The right hangback recession has an important advantage as it eliminates the complication of retinal perforation that can occur with standard fixed suture recession, whilst avoiding under or overcorrection that can occur with traditional hangback recession. Our results showed that we had as good surgical results with the hangback recession as standard fixed suture recession with no complications. This technique increases patient safety without sacrificing surgical outcomes and can be especially useful in patients with thin sclera, such as patients with high myopia or those with difficult posterior exposure. Thank you for your attention.
Thank you, Yaning. Our next speaker will be Dr. Kabri Wu, and she'll be talking about the use of neuromuscular blocking drugs during strabismus surgery.
Thanks, Dr. Dotchin. I'm Kabri, I'm a medical student at Queen's. I'd like to thank Dr. Struwe and Law for their guidance and insight throughout this project. We have no conflicts of interest to disclose. The forced duction testing, or FDT, is used in strabismus surgery to help differentiate between paretic muscle and restriction. There are two types of muscle relaxants. So there are depolarizing ones that cause sustained increased extraocular muscle contraction. These interfere with FDT and shouldn't be used in strabismus surgery. There are also non-depolarizing ones, such as rocuronium, which are commonly used in surgery to facilitate intubation. And some anesthesia textbooks have historically advocated for their use during FDT to eliminate the effects of variation in muscle tone caused by the varying depths of anesthesia. However, there are very few reports regarding this, and the use is actually quite controversial. Well, the purpose of our study was twofold: to first conduct a systematic review on this topic, and also to evaluate the current practice patterns of pediatric ophthalmologists in Canada and the US primarily on their use. So for the systematic review, 3 studies met our inclusion criteria. Notably, one 1999 UK survey of 214 anesthesiologists found that muscle relaxants were only used in 45% of children and 34% of adults undergoing strabismus surgery. The other trials found succinylcholine to cause significant muscle contraction and intraocular pressure elevation, while pancuronium does not. And rocuronium significantly decreased the oculocardiac reflex compared to no use or succinylcholine use. However, so overall, there were no RCTs evaluating the use of non-depolarizing muscle relaxants during strabismus surgery. And so overall, the literature doesn't actually support the use of muscle relaxants for FDT. So we created a 23-question survey and received 77 complete responses. Thank you to everyone listening who contributed your experiences. And the countries of practice are plotted here, with 54% practicing in the US, 21% in Canada, and 25% in other countries. Around 80% either practiced in an academic or private center, and around half had been in practice for over 20 years. And 70% had done their fellowship in the US, and 87% were not taught to administer MRs, and only 12% were taught to request them. So out of the 77 respondents, 7 reported requesting muscle relaxants. And we found these respondents who use muscle relaxants to be significantly more likely to be practicing in countries outside the US compared to those who don't. So 2 were in Canada, 1 in Australia, Mexico, and the UK. Around half had trained in the US and half in other countries. And they had been in practice for a similar number of years to those who don't use muscle relaxants, but they were not non-significantly more likely to practice in an academic setting rather than a community setting. And this was echoed in the 1999 survey that found that those who use muscle relaxants were only in regional specialized centers rather than smaller centers. Notably, 4 out of 7 use in all strabismus cases for both adults and peds, while others use them in some cases, but not others. 5 used rocuronium and 2 did not specify. So while 7 respondents used MRs, 19 had noted that there were benefits with using FDT, which we'll discuss later. Reasons for not listing are listed here, with not needed as the #1 reason. And while most participants noted no benefits, some benefits included increased accuracy of FDT and ease of surgery. These include better visualization and changes in muscle activity, as well as globes maintaining primary position during surgery. Notably, there's also decreased oculocardiac reflex listed. So 34 respondents thought MR's prolonged surgery time or resulted in a longer recovery from anesthesia, and 19% noted other drawbacks such as increased risk of complications, decreased ability to adjust during surgery, or check results directly after. And interestingly, the oculocardiac reflex was listed as both a benefit as well as a drawback. So in conclusion, inadequate evidence support the use of MRs to maintain paralysis during strabismus surgery. 7 of 77 respondents used MRs mostly to facilitate accurate FDT and for ease of surgery. And drawbacks appear to outweigh benefits for most ophthalmologists, with the biggest risk being increased turnover time between surgical cases. And we conclude that improved communication between anesthesiologists and pediatric ophthalmologists, as well as evidence-based data to guide practice patterns, are needed and important to ensure the best care for strabismus patients. Thank you, and here are references.
Thank you. So we are running about 4 minutes behind, but there is one question that I will ask. And then if we can just put any questions in the Q&A, and we'll try and cover as many as possible at the end of the next group as well. So this one is directed to Yaning. This is from Etzel Ing. When you use the right grooved hook, do you find that you have to adjust your recession if you use a table? Example, add 1 millimeter.
No. I answered it on the chat, but I use the grooved hook for all my cases, and I use the same surgical tables that I would otherwise.
Thank you. So we're going to just keep moving in the interest of time, and I will let Chris introduce the next speaker.
Thank you very much, Stephanie, and thanks to all the last speakers. Our next speaker will be Dr. Christine Law, who will be talking about missed appointments in a Canadian tertiary care academic center, pediatric ophthalmology, and adult strabismus service, rates, and financial impact.
All right, well, thank you so much, COS and COS, for allowing us to share our research. I'll be presenting on behalf of Evening Struby and Gregory Hawley on the rates and impact of appointments in pediatric ophthalmology and adult strabismus service. We do not have any financial disclosures. So patients' no-shows and last-minute cancellations pose a substantial challenge to pediatric ophthalmologists, where we often book fewer patients with longer time slots compared to our colleagues who serve the adult population. Missed appointments have a number of deleterious consequences for both the patient and the healthcare system, such as inefficient utilization of healthcare workers, decreased productivity, loss of revenue, increased wait times, patient dissatisfaction, and potential detriment to the patient-provider relationship. In non-ophthalmology pediatric clinics, no-show rates have been shown to be as high as 35%. And among adult ophthalmology clinics in Canada, level of education inversely corresponds to high rates of no-shows. Despite these studies, there's a lack of data regarding the overall no-show rates in Canadian pediatric ophthalmology clinics and the associated costs to the healthcare system and patient wait times. Thus, we wanted to quantify the no-show rate over the course of a year at a Canadian pediatric ophthalmology outpatient clinic and the associated patient and financial impact. This was a retrospective chart review over a one-year period between June 2018 and May 2019, looking at clinic data from 2 pediatric ophthalmology and adult strabismus surgeons at Queen's University. Every patient booked over the 12-month period was recorded and demographic factors listed here collected. Statistical analysis was performed on the demographic factors, and financial cost of the missed appointments was calculated using Ontario OHIP billing codes and our local hospital pay rates. The study was approved by our university ethics. So our results showed that overall, the no-show rate for the 12-month period was about 18.4%, with no difference between the 2 providers. Pediatric patients less than 18 years old were more likely to no-show than our adult strabismus patients, and males were more likely than females to no-show. However, neither of these demographic factors were statistically significant. In terms of the patients, though, significantly more new patients compared to return patients no-showed, and within the group of patients that no-showed, patients who repeatedly no-showed were more frequent than individuals who only missed 1 appointment. Based on the diagnosis itself, surgical strabismus patients were the least likely to no-show. Interestingly, looking at across the months, it was fairly consistent for the no-show rates, except for January, where there was a significantly higher no-show rate. In terms of factors where there was no difference, we found that the distance from home to clinic played no role, neither did a morning or afternoon appointment, and the referral source was not statistically different, although we did notice that the highest percentage of no-shows did tend to be from nurse practitioners, although this did not reach statistical significance. When we then wanted to look at the patient impact, we found that our no-show rate of 18.4% would be calculated to equivalent of 34 full clinic days lost, or alternatively viewed as an additional 2.5 months wait time to be seen in our service for non-urgent patients. And by analyzing the financial impact using our Ontario billing codes, the average lost physician billing revenue was $382.33 per clinic day. And on our hospital fee schedule, the additional orthoptic lost time was $38.63 per clinic day, and the secretary lost time to rebook no-shows was $4,302.73 per year. We also have volunteer and other office overhead costs, which we were unable to quantify, but just using these 3 values alone, the physician cost per day was $437.51, and in a year, $80,501.84. So our study did show that no-show rates are fairly consistent with higher rates that are seen in other pediatric specialties. And within our data set, there's a no-show rate for new patients, non-eye care specialist referrals, and repeat no-show offenders. So perhaps increasing the education to the patient caregivers and referral sources about the importance of attending appointments will decrease the no-show rates. As evidenced by our calculation, there's a significant impact on patient wait time and financial flow through, and with the current COVID environment, it would follow that the impact may be even higher. Some of the limitations of our study include the likely underestimation of patient and financial impact, as our efficiency at an academic hospital center may be slightly lower than that compared to our community colleagues. We also were unable at this point to tease out and include other hospital overhead costs, which would increase our numbers. Lastly, our current policy is to allow 2 no-shows and then request a new referral, so perhaps a financial penalty may have decreased our no-show count. In terms of future directions, we're planning to take our research and implement some of the changes that we saw did impact our no-shows in the hope of lessening patient wait time and reduce financial impact. But in the current COVID world where appointment numbers are significantly reduced, we hope these new measures may help everybody reduce their no-show rates as much as possible.
Thank you very much, Dr. Law, for that great talk. We're going to move on to the next speaker, Dr. Stephanie Kletke, who will be speaking about pediatric glaucoma suspects, characteristics, and outcomes.
Thanks for the opportunity to present today. None of the authors has a financial interest to report. Children suspected of glaucoma are frequently referred to pediatric ophthalmology practices, yet the current literature on pediatric glaucoma suspects is limited. The prevalence of glaucoma suspects among pediatric glaucoma practices ranges from 31 to 46%, yet the prevalence in the general population is unknown. The risk factors for progression of these children to glaucoma are also unknown, and there's a lack of evidence-based or consensus practice patterns for these children. Our aim was to determine the characteristics and outcomes of pediatric glaucoma suspects and their risk factors for progression to glaucoma. We conducted a retrospective cohort study of children under 18 years of age who were diagnosed as glaucoma suspects at the Children's Hospital of Philadelphia over a 6-year period. Our outcomes included conversion to a diagnosis of glaucoma, non-glaucomatous cupping, either prematurity-associated pseudoglaucomatous or physiologic cupping, treated ocular hypertension in the absence of a glaucomatous optic neuropathy, and children who remained a glaucoma suspect. We included 887 children of mean age 9.3 years over a wide range. 55% had at least one follow-up, for a mean of 4 visits, and their mean follow-up duration was 1.7 years. Around half of the children had OCT of the retinal nerve fiber layer, 1/5 had visual field testing, and a minority had gonioscopy performed. Bilateral symmetric or asymmetric optic nerve cupping was the most common reason for diagnosis of glaucoma suspect in these children. This was followed by a family history in 1/4 and ocular hypertension in 15% of children. The other reasons were less common and included periocular lesions or systemic associations. So in the subset that had at least one follow-up, 2/3 of the children remained glaucoma suspects at the last follow-up, while 20% were considered to have physiologic cupping and 10% pseudoglaucomatous cupping. At the mean of 1.7-year follow-up, around 3% of the children were converted to a diagnosis of glaucoma. One child was treated for ocular hypertension. This table shows the baseline IOP, pachymetry, and cup to disc ratio for these children stratified by outcome. The baseline IOP did not differ for children with glaucoma compared to the other outcomes. The baseline central corneal thickness appeared greater for those with glaucoma, though this did not reach statistical significance, possibly due to the small number of children in this group. The baseline cup to disc ratio also did not differ for children with glaucoma compared to the other outcomes. So 14 children were diagnosed with glaucoma at a mean age of 8.4 years. Half of these were primary and half were secondary, such as to Sturge-Weber syndrome or ocular trauma. And the mean time from their presentation to diagnosis of glaucoma was 1 year. In most cases, the diagnosis of glaucoma was supported by ocular hypertension. In 43% of the children, they also had progressive thinning on OCT, 21% showed a change in their optic nerve appearance, and 14% had a new visual field defect. So multiple risk factors for the diagnosis of glaucoma were evaluated, including baseline IOP and cup to disc ratio, presence of a periocular lesion, systemic associations, and family history of glaucoma. The only significant risk factors were a baseline IOP above 24 and presence of a periocular lesion, such as in Sturge-Weber. So in conclusion, optic nerve cupping, family history, and ocular hypertension were the most common reasons for a diagnosis of glaucoma suspect in these children. In our cohort of glaucoma suspects, the risk of conversion to a diagnosis of glaucoma was low. It was 3% over a mean of 1.7-year follow-up. This translates to an incidence rate of 1.7% per person year. While baseline cup to disc ratio and a family history of glaucoma are important predictors of glaucoma progression in adults, these were not predictive in our pediatric cohort. Baseline eye pressure above 24 and having a periocular lesion did carry higher risk for glaucoma progression. Thank you.
Thank you very much, Stephanie. We'll move on to our last speaker, who is Cabri Yu, and she'll be speaking this time on yield of clinical genetic testing in inherited retinal disease, experience at the Hospital for Sick Children in Toronto.
Thanks so much, Dr. Waite. I'm Cabri, I'm from Queen's University. I'm excited to talk about the clinical genetic testing in inherited retinal disease. Massive thank you to Dr. Aon and the Aon Lab for their continual support. We have no financial interests. So inherited retinal dystrophies, or IRDs, are a large group of genetically heterogeneous disorders that cause blindness irreversibly. They affect around 1 in 3,500 individuals. And for some genetic diseases, such as cystic fibrosis, it would be easy to make a genetic correlation since it's monogenic. But for IRDs, there are over 270 genes being implicated. And some genes encode for different phenotypes, and some diseases are caused by multiple genes. And this genetic heterogeneity is why molecular diagnosis is not reached for many patients. In literature, the diagnostic yield of genetic testing for IRDs is only around 50%. And this is important because although an accurate clinical diagnosis can be reached by fundus exam, history taking, and with tools like ERG or OCT, genetic testing is necessary to confirm the specific phenotype, and segregation analysis can address the inheritance pattern with greater precision. So this is a retrospective study that aims to first determine the clinical diagnoses of patients at sick kids, evaluate the proportion of IRD patients seen, including the probands for the patients and the carriers who are the family members, of having conclusive genetic testing results. And thirdly, to identify clinical subgroups of patients who, with a higher likelihood of having causative mutations identified. So first, we identified patients who attended the ocular genetics program at Sick Kids in 2016 and 2017. We recorded their baseline information like gender, clinical diagnosis, and mode of inheritance. And then we retrospectively determined the main genetic diagnosis, including whether a mutation was identified, not identified, or whether it was a variant of unknown significance. And then whether this genetic result or counseling had influenced the final clinical diagnosis. So out of the 647 patients counseled by the ocular genetics program, 64% were probands, so patients, and then 35% were the relatives with carrier mutations. We excluded patients who didn't complete genetic testing and patients whose proband or carrier statuses were unknown, so only 616 patients were analyzed. Among all the probands, 281 had an IRD. And the ocular genetics program also sees many other patients with other clinical diagnoses, as shown in the chart. So out of the 440 patients with IRDs, mutations were considered pathogenic or variants of unknown significance in 84% of patients. These mutations are causative in 63% of the cases, and the rest were VUS. So these are mutations where the gene's been previously implicated in the condition, but the specific variant hasn't been shown to cause the same disease, or their pathogenicity score isn't quite high enough. And here you can see that the carriers have higher positive results because we're more likely to screen certain family members based on inheritance pattern. So this table shows the distribution of modes of inheritance in the top 5 included probands categorized under clinical IRD. And this portrays clinical subgroups that had a higher likelihood of having causative mutations identified, which are namely retinitis pigmentosa, Leber congenital amaurosis, and macular dystrophy. Mutations weren't identified in 69 of the 400 probands, and of these, 39 had a generic diagnosis of retinal dystrophy. We found that an unknown mode of inheritance significantly reduced the chances of identifying a causative mutation as expected. So there were 29 probands whose clinical diagnosis was modified based on the genetic result or counseling as shown in the table here. So our results show that we're able to identify a genetic cause in around 84% of IRD patients, including families at Sick Kids, and they were labeled causative in 57% of probands. And that's 57% of patients with IRDs that now have the chance to know their genetic cause of disease. They're able to inform their families of the risk of disease, and identify potential younger pre-symptomatic family members. And they can be potentially eligible for the increasing number of clinical trials that show regaining of vision function with gene-targeted therapy. And this number is expected to be higher in the future, and it currently is also higher than reported in literature as well. This is because variants of unknown significance are continuing to be recategorized as pathogenic variants, and newer technologies are used for genetic testing. While diagnostic accuracy is high in some clinical presentations like LCA and macular dystrophy, others such as generic retinal dystrophies require further investigation. And therefore, when we assess patients with IRDs, genetic testing and counseling is both feasible and instrumental in the diagnosis and management of patients. Thank you for listening, and here are references.
Thank you very much, Cabri, and our other speakers for the wonderful talks. First of all, I just wanted to remind everybody at the end to complete the evaluation for the session, and also for those that are members of CAPOS that there is a business meeting afterwards, which you should have had a separate invitation for, that will be starting in approximately 15 minutes. And you'll also see in the chat that the invitation just showed up there as well. For questions, first I'm hoping that one of our colleagues from Queen's, who has been so kind as to already answer this question in typing, if they could just comment on their current wait lists for patients to be seen. Obviously it'd be different depending on the diagnosis, but also whether or not they're currently double booking their clinics, and if so, how many numbers they're choosing to double book by.
Yeah, so Chris, that's a many different points to address there. So in terms of Eaning and Eye's clinic, so we're the 2 pediatric ophthalmologists at Queen's. And so in terms of our patients, so we always double book at least sort of 3 or 4 spots in the morning and an additional 3 to 4 in the afternoon, just traditionally. Also, if there are repeat patients that we know traditionally are no-shows, we do ask our secretary to double book those as well. The challenge is even with patients who may not, who are new patients to us, we don't know whether or not they're going to no-show. And so oftentimes our new patient slots, I do have them double booked because, as you can tell even from our data, the new patients do have a higher tendency to no-show. In terms of the wait times, so yeah, our wait times currently, it varies depending on pediatrics versus our adult wait times are sort of through the roof in terms of sometimes upwards in years in terms of some of the surgeries for them. And then for the patients, there's different wait times for the new patients and their diagnoses, and also for the repeat patients, depending on the stability of their condition. I would be challenged right now with COVID to give you a specific number in terms of our months and potentially sometimes years wait time. But yes, it's definitely getting up there. And with COVID, even just these past few months, despite our secretary talking to the parents directly on the phone, knowing that they're supposed to come, we still continually have no-shows and sometimes repeat no-shows if they're even when we keep booking them. So we just thought it would be useful to discuss this at the CAPOS COS level to see different approaches and show what our experience has been.
Thank you very much. The next question will be for Stephanie Klutke. Question about whether or not family members were examined in the cases of suspicious optic nerves.
In some cases they were. It was a retrospective study though, so it wasn't uniformly performed. In cases where family members were examined, that probably contributed to the thought process of the ophthalmologist that it was more likely in keeping with a physiologic cupping, but it was not uniformly performed given that it was retrospective.
Thank you. So that's it, guys. That's all for this pediatric session. Thank you everyone for coming. We've had a great attendance. I'm super impressed and amazed. And for everybody who wants to come, the business meeting is in 15 minutes. So I'll see you back in our virtual room. And like Chris said, it's you'll see it, the link on the chat. And I want to thank all our panelists for all the wonderful work that they've done and the time that this took. So thank you all very much.